comes to corneal blindness, corneal transplantation remains the primary sight restoring procedure. However, in patients suffering from bilateral corneal blindness, not amenable to conventional penetrating keratoplasty, such as in Stevens-Johnson syndrome, keratoporosis is the only viable option. Though different keratoporosis are available, based on the long-term anatomical and functional outcome, the choice of keratoporosis in severe end-stage ocular surface disorder is preferably the modified osteoidentakeratoprosis or MOOKP. Studies have shown that in eyes with extensive scarring and vascularization associated with severe dryness and keratinization of the ocular surface, MOOKP gives the best long-term retention rates along with excellent visual recovery. MOOKP is also known to have minimal complications of all keratoporosis available today. Through this video, we would like to illustrate the surgical steps of this complex yet gratifying procedure performed in a 52-year-old Stevens-Johnson syndrome survivor. Right patient selection is extremely crucial in this procedure, and an ophthalmic surgeon must always bear in mind the indications and contraindications of MOOKP. Surgical planning begins right in the OPD. Thorough slit lamp examination is performed. Vision of at least perception of light must be present. B-scan is done to assess the posterior segment. Axial length of the eye is measured using an A-scan or B-scan. Intraocular pressure in most cases can be assessed only digitally due to the damaged ocular surface. The patient is then sent to a dental surgeon who assesses the health of the buccal mucosa and teeth. A monoradicular tooth, preferably canine, is selected for MOOKP. Patient is advised to stop use of all forms of tobacco and is asked to use mouthwashes regularly. Detailed pre-anesthetic evaluation is performed by anesthetists as MOOKP is performed under GA and requires oral and nasal intubation. MOOKP is done in multiple stages spread over a period of 6 to 9 months. Initial stage, stage 1A, is a preparatory stage. Corneal transplantation to replace the damaged cornea along with removal of iris and lens is done. Retina and optic nerve is examined intraoperatively and eye surface is totally closed. In stage 1B, buccal mucosa of 3 cm diameter is harvested from the cheek. Following dissection of the ocular surface to bare the cornea and sclera up to the insertion of the recti muscles, the buccal mucosa is used to cover the ocular surface. In stage 1C, canine tooth with its surrounding bone is cut and removed. The root of canine tooth with its bone is thinned to a 3 mm plate. At the center of the dentine, a hole is drilled. Enamel is then cut off. To the hole in the dentine, an optic cylinder is fixed. This composite, called as the osteodental acrylic lamina or ODAL, is implanted in the subcutaneous pouch in the cheek of the infraorbital area of contralateral eye. In the final stage, stage 2, performed 3 months after stage 1C, lamina is retrieved from the subcutaneous pouch with its fibrovascular capsule. Mucosa is reflected. Center of the cornea is refined. Lamina is placed on the cornea in such a way that the posterior end of the optic cylinder passes through the opening created in the cornea. Lamina is then secured to the sclera. The mucosa is then used to cover the lamina, and the central part of the mucosa is opened so that the anterior end of the optic cylinder is exposed. This creates an optically clear window for the light to enter the eye. After undergoing MOOKP, this patient had excellent visual recovery. From being dependent on others, she is now performing all her activities independently.
സാനിയോപാപ്പി അത് എടുക്കാൻ സാധിക്കുന്നുണ്ട്. ചില കാര്യമ്പോൾ നമുക്ക് അങ്ങനെയൊക്കെ വെക്കാൻ സാധിക്കുന്നുണ്ട്.
An eye for an eye makes the whole world blind, but a tooth for an eye can make the blind see. Till date, only 14 centers around the world offer this complex procedure as a treatment option for such unfortunate patients. By embarking on this journey, a new beacon of hope for the blind is established in Kerala.
What are your worst fears after MOKP and what is the post-op treatment?
The worst fear is not related to OKP. The worst fear is, restoring sight to a blind person and then future loss of that vision. Anybody who do keratoprosthesis have faced this. Keratoprosthesis is still not a perfect science. There are a lot of, science which we don't know. None of these are perfect procedures, and they are all, procedures which can have devastating complications immediately after the procedure or any time during the lifetime of the patients. So these patients are on follow-up lifelong, regular follow-up. We have to, actively look for any signs or, or pointers towards early problems and tackle them. Then yes, we can have a real good long outcome in these cases.
What about endophthalmitis in specific?
Very, very rare in OKP. The only
Compared to Boston and ROK Pro?
Yes, very rare.
Why?
The whole osteodental acrylic mucosa complex is a very resilient complex. Okay, you're actually recreating what is in the mouth on the eye. So it's something which is exposed to the environment with all the microbial flora or whatever we can say. So unless there is a problem with the mucosa, endophthalmitis practically doesn't happen after a successful OKP.
Any lubricants over this? No.
We do ask them to use one of the lubricants, any of them, on the surface, on and off, and use an ointment at night. The problem here is that you have a complex on the eye, which is actually, outside the eye protruding, so the lid closure won't be there. So it is always exposed. So at night we ask them to use an ointment, and probably my preferred choice is a CMC drops on and
they
off.
use a eye shade at night, like they cover
we
because they can see, they will be continuing sleeping, so they have to sleeping with eyes open. It's like that.
Yeah, we ask them to darken the room and use a hat with a shade in the mornings to prevent the glare. That's what we do.
How many cases have you done so
One.
far?
As of now, in this center, we have completed one.
Okay. What's the follow-up of this patient?
Oh, we completed in November 22. Nearly a year
Almost
now.
a year
Yeah,
now.
nearly a year now.
Did you face any challenges after that?
After that, in this particular case, after the procedure, no.
Nothing.
Prior to that, yes, many.
And what is the toughest procedure in the whole process?
The
And how
stage
long does it take?
1B, during the procedure,
Yeah.
1B
Procedure
plus.
is stepwise, right?
Yes,
So
stage
which is, the
1A
toughest
is
in your-
practically not a very difficult procedure because all of us ocular surgeons can do it. It's 1B and C, the oral mucosa and the dental part, that is the most difficult. One, we are not used to it. Second thing is long duration surgery. That 1B plus C together takes about 8 hours to complete under general anesthesia. We need to have a very good GA backup
Yeah.
system. Need to have the help of oral maxillofacial surgeons. Yes, that is the most difficult part.
Okay, wish you the best.
Thank you.
So, दान देनी पड़ेगी. That's the Hindi word.
Sorry?
दान देनी पड़ेगी. Well done.